Good afternoon. Thanks, Moritz.
Thanks.
I'd like to first acknowledge my co-authors here. Joel Wells did a lot of the work on the long-term outcome I'll show, and my partner, Perry Schenecker, has been involved in the care of these patients over time. As you have heard, the Bernese PAO has been a very effective intervention for symptomatic acetabular dysplasia. It's very important that we look at intermediate to long-term follow-up to guide future innovations and refinement of the procedure, and that we do this at different institutions. So in this talk, I'll go over our mid to long-term PAO outcomes in St. Louis. This is an average 10-year study. We certainly have a lot longer follow-up here in Bern and then in Boston, which I'll go over briefly. And then we'll look at some of our current refinements in PAO surgery that have really been in result to our mid to long-term outcomes and just give you a sense of how we're doing things currently. So this is a summary of the Bern and the Boston cohorts. So we have all learned an incredible amount from these studies looking at long-term outcome. Bottom line here, at 18 to 20 years, we have 60 to 75% survivorship of the natural hip joint. And these articles really were fundamental in terms of our understanding of the surgical technique, the indications, and the predictors of outcome. So our work has built on the work from these other institutions. So in this specific study, we looked at our first over 200 hips. 154 of the hips were included, and we had 86% follow-up on this cohort. Mean 10-year follow-up, they all had classic acetabular dysplasia. They all were symptomatic, and we thought they had adequate congruency of the hip. We looked at standard patient-reported outcomes, X-ray parameters, and Kaplan-Meier survivorship. We specifically looked at symptomatic hips, which I think we all have realized now is a very important subgroup of patients. So for a modified Harris hip score under 70 or a WOMAC pain greater than 10 points, those were considered symptomatic hips. When we did our statistical analysis, predictors of failure included both hips that had converted to total hip and those that were deemed symptomatic. We used modification of the procedure, as we all know, by Gons and colleagues here in Bern. Importantly, in this initial cohort, no abductor takedown, fluoroscopic use during the procedure, rectus takedown in this early series, and then a femoral osteoplasty was introduced during the series on an as-needed basis. These are the patient demographics. So again, 129 patients, 154 hips. 22 or 14% lost to follow-up. The majority women, as you would expect, average age 26 and BMI 24. These are our patient-reported outcomes very briefly. So Harris hip score improving by 20 points, UCLA score improving by almost 1 point, and again, the UCLA activity not an ideal outcome measure, which I'll talk about in a few minutes. In terms of the WOMAC, very major clinically important differences relative to pain, stiffness, and physical function. Radiographic correction, the hips were fairly well normalized as shown in the red circle with a center edge angle of 30, anterior center edge angle 31, and a tonus angle of 4 after the PAO. The most common change in tonus grade in this cohort was from tonus 0 to tonus 1, and that was in about 14% of the hips. So these are the survivorship analysis of this cohort. So 15-year survivorship, 92%, and that's for total hip arthroplasty, not including the symptomatic hips. Severe dysplasia has been a predictor of poor outcome in some series, and in our series we didn't really see that. Lateral center edge angle less than 5. The survivorship of those hips was as good as the whole cohort together. So this is the bottom line with the overall results. So 92% survivorship at 15 years with our Kaplan-Meier analysis. 5% underwent total hip. We had the 16% symptomatic hips, which I think we all realize is a very important group of patients as we move forward and try to improve the outcomes of this operation. Our factors identified that are associated with composite failure, so that's total hip or a symptomatic hip, included fair or poor congruency, overcoverage with a lateral center edge angle over 38, and no concurrent osteoplasty. So in a sense, osteoplasty was protective in the hips in terms of risk for failure. So those are our historic data. We continue to follow that cohort over time. So what are we doing now? Just real quick, I'm going to touch on 4 changes in the practice over time. So we'd all agree, I think this is an excellent patient for a PAO procedure. These are some of the refinements in the procedure that many in the room have been a major part of in terms of improving the procedure. I'm going to touch real quickly just on concurrent osteochondroplasty, concurrent scope, activity expectations, and PROMIS as a new potential outcome tool in this patient population. So I'll go through it pretty quick, but just wanted to give you a snapshot of some more current things that we're doing in our practice. So in terms of the osteoplasty, in our long-term survivorship, that was associated with improved outcomes or protective of the hip. When we first started to think about doing this on a more regular basis, we looked at the safety of that procedure. And in this article in the journal in 2012, we showed that there was no difference in terms of complications or outcomes, whether we performed an osteoplasty or not. So we felt comfortable with that part of the procedure and really lowered our threshold in terms of using the osteoplasty. So currently, it's probably done in about 75% of our hips. So we do the PAO, we examine the intra-rotation flexion. If I'm not happy with that, then I go ahead and do the arthrotomy and the osteoplasty. So this is the type of patient where we would definitely do an osteoplasty. You can see characteristics both of hip instability and FAI treated with the combined procedure. So that's a big part of our practice now. How about the role of arthroscopy? You've heard other speakers talk about that. Rafa Sierra summarized the safety of that procedure, which we looked at. So we didn't, again, see any difference in complications relative to the PAO alone. So we have used that selectively. And in this study, we looked at our first 83 hips at relatively long follow-up for the combined procedure. So at 7 years, primary outcome being total hip conversion. And again, we looked at symptomatic hips. And one of the main reasons we wanted to combine the procedure, add the arthroscopy, was to try to eliminate or reduce the number of symptomatic hips we have over time. So these are our outcomes, a very nice bump in the Harris hip score. Like Ira mentioned, these may be sicker hips in that 55 pre-op hip score is really low. So these are sicker hips probably that have been selected for the combined procedure. So we get improvement in hip scores, improvement in activity. But again, we have this residual 18% of the hips remaining symptomatic. So really didn't resolve that subgroup of patients. So the outcomes were good, but certainly we can't say it's a better procedure than the PAO alone. And Paul Belay is now leading a RCT out of Ottawa, which I think is a very important study as we try to sort this out over time. This is a patient today we would think about the combined procedure. So a little older patient, substantial intra-articular disease that we can repair and assess the appropriateness of the joint for the PAO. Finally, or the third thing, currently activity. Our view of activity is a little different than it has been in the past. And in this study, we recently looked at activity real quickly. At 7-year follow-up, 93% of the patients were not limited by their activity after PAO surgery. So again, very optimistic in terms of returning patients to their pre-op activity. And then finally, how about PROs? Just real briefly, PROMIS was introduced by the National Institutes of Health. We've incorporated that into our practice. It's a computer adaptive testing that we use with our patients. So the number of questions is reduced and the system adapts the questions to the previous question answered by the patient. And we have compared this recently to some of our legacy measures, looking at pain and physical function in the PAO population. And really, most striking is the removal of the ceiling effect, which I'll show here with the Hoos and the Harris hip score. So if you see on your left, you can look at the PROMIS, the normal distribution pre-op as well as post-op in terms of PROMIS pain. If we look at PROMIS pain with the Hoos, you see pre-op, we have relatively normal distribution, but then we have a large ceiling effect post-operatively. So the PROMIS certainly improved in terms of removing the floor and ceiling effects. And then finally, same thing here with Hoos ADLs and the modified Harris hip score, both showing major sealing effects post-op, which we don't have with the PROMIS tool. So I think this tool does have some application for our patients in the future. So in conclusion, the experience has demonstrated good clinical outcomes, 92% survivorship at 15 years, but we have this 18% symptomatic hips that we need to work on moving forward. Femoral osteoplasty is safe and it seems to be protective, at least that's what our data suggests. So we're relatively aggressive with that. Joint incongruity and acetabular overcoverage are detrimental in our long-term outcomes. The benefit of concurrent hip scope needs to be better defined. Studies are ongoing, and activity levels we're more optimistic about that than we have been in the past. And then again, the PROMIS tool seems to have some merit as we move forward. Thanks for your attention.